Well, good afternoon, everybody, and welcome to this NOLEX webinar. We're pleased to be bringing you this with Antibiotic Research UK, and we're looking at the question of UTIs and how we can optimize patient management and sample to research. This is going to be done by Eileen Bryson, who's a patient support lead at Antibiotic Research UK, and Peter Montali, who's a clinical lead for the Department of Microbiology at the University Hospitals of Coventry and Warwickshire NHS Trust. Eileen, if I could ask you to introduce yourself, please, and let everybody know a bit of background.
Hi there, good afternoon, everybody. And I'm just trying to share my screen as we go along. So Rob, can you tell me if it's coming through?
Yes, that's coming through fine for me.
I'm just hoping I've got the, I'm going to stop it. So I'm just going to check I've got the audio on as well. So my name's Aileen. I'm a pharmacist by background, and together with my colleague Dee, a critical care nurse, we make up the patient support team at Antibiotic Research UK. So this afternoon, really delighted that you've all managed to tune in, and thank you. And thank you to NOLEX for hosting us this afternoon. And to Dr. Peter for joining with us. So this is kind of running order that we're going to go through, and I'm going to talk a little bit about the work of the charity and how we came to have this webinar this afternoon, very much from the perspective of somebody living with an antibiotic resistant infection. And as Rob said, we're focusing on UTIs because most of the calls we get to the charity are over 60% are from people suffering from chronic UTIs. So, I think you did get a biog. I'm not going to go into background of both of us, so everything's a little snapshot at the moment. But between Dee and I, we make a tag team to answer patient calls and emails to the charity, a lot of them are about testing and diagnosis, which is why we asked Dr. Montali if he would do this webinar with us this afternoon, because he's been working with the charity and we're delighted to have his expertise. And then we'll have lots of time for questions and answers. And you can also put them in the chat, I believe, as well, Rob, and you're going to keep a little eye on that, aren't you?
Yes, that's correct. Yeah. And we'll answer some of those questions at the end, yeah.
Excellent. Okay. So the charity is a very small charity. We're a medical research charity started 10 years ago. And this is the three arms that we have. We provide research grants to look at innovative solutions and alternatives to antibiotics through our research arm. We're very much about raising awareness, because our understanding from what we hear and what we see around us is that in general, the public don't understand much about antibiotic resistance until it affects them or one of their family, friends or loved ones. So we do have, with both public and professionals, a job to actually raise awareness about the whole issue and about how we can all contribute to preventing it. And the patient support arm, which Dee and I are involved with, is about trying to improve the lives of people as they come to us. And it was only started about 4 years ago when we started having calls and emails to the charity from people suffering from resistant infections. And the timing is good this week because next week we have World Antimicrobial Awareness Week, and we tend to see a lot in the media around about this time in November, and then we don't see so much for the rest of the year. So it does tend to disappear a little bit, and only those who are involved in it are really aware of what's going on sometimes. So it's really good to have the opportunity to highlight things this week. And I'm not going to bore you with lots of statistics because I'm sure as healthcare professionals, you're all very aware of the scale of the problem that we have. But I don't think I'm being overly dramatic when I talk about a silent pandemic coming up with us. And we're all a bit pandemicked out after recent events with COVID, but it isn't too dramatic to talk about it like that. And Dame Sally Davis, when previously, quite a few years ago now, who was the previous chief medical officer in England, she said that this is something which could kill us before climate change does. So we're talking about something on that scale and a massive public health challenge, which we have to address. And just a couple of the top line numbers on it. There are, we know already, about 5 million people who die either as a direct result of an antimicrobial resistant infection. I'm going to start saying AMR for short because it's a bit of a mouthful, or when it contributes to their death, but it's not often put as the cause of death on the death certificate. So the figures that we do see could probably be underestimated. And if we don't change things, the estimated figure for 2050 for infections which will be the cause of death will overtake everything else that we're much more familiar with, and will be on at least 10 million by then. So we are talking about something which is going to have a huge impact on normal life as we know it. And just a little bit closer to home, we know that every day in England, 178 people are diagnosed with a resistant infection, and about 25% of infections, bloodstream infections, I think that one is, are already resistant to at least one antibiotic. So it is something which is very close to home for all of us. So this slide shows you some of the aspirations really of the charity, because we really need to extend our reach and start working with other organisations who are also in this field, and thinking more about collaborating. So we do want to work with you to raise awareness so that we can help you in your practice with your patients. We're going to talk a bit about the resources that we have, but you can see that it's a huge arena for work to be done in overall. So we are just at the beginning of some of our policy work and some of the things that are listed on this slide here. So what do we do at the Patient Support Helpline? Well, we take emails and calls from people and we answer them on a confidential one-to-one basis. And we really just, sometimes it's just a listening ear, and that is all that's actually required. People tend to find the charity by Googling us mostly. And at that point, they're very much at the end of their tether. They are usually feeling quite despondent, quite low in mood, quite frustrated. They don't know where to turn, and they're looking for some kind of magic solution to a really difficult situation that they have found themselves in, or one of their family. And of course, we don't have a magic solution, but we do provide that listening ear. We point them in the right direction to information. We make sure that we use websites which are verified and give them evidence-based information, give them guidelines. We signpost them to other information and to websites which might be useful. We help them navigate their way through the NHS, see where they are in their patient journey. We help them frame the questions that they might want to go back to their GP or their consultant and talk about. And we go through some of the options, which you can see on the screen there, where we might talk about what has already been discussed and what might be discussed. And as I said, chronic UTI is the most of the group. We also have quite a lot of skin and respiratory infections. So what we don't do is we don't give them personal medical advice, and we make that very clear. But people are just usually so grateful to have somebody who understands the situation and can take the time, and we have the luxury of the time to listen to them. So what we hear, I'm going to run through a few slides now, and I'm just going to give you a flavour of the sort of things we hear from people who get in touch with us when they are feeling, as I say, very, very scared. And they're very scared of what comes next. They are terrified they're going to have sepsis. They might have had sepsis and they're terrified that they're going to, the next time they have a bout of sepsis, it's going to be fatal. They are worried that the next antibiotic prescription is not going to work, as well as often the ones they've been on several courses of antibiotics already, no resolution to the infection that they're suffering from, and they have quite real and understandable anxiety about what the future holds for them. And as I said, they are looking for lots of alternatives, which we can't wave a magic wand. We can only talk them through the situation and help them try and think a bit clearer about what their options are and what they must do. They quite often feel they look well on the outside, and people don't understand because they're still suffering from symptoms on the inside. They are in a lot of pain and a lot of discomfort. They feel let down by the system. Now, we all know the system is not ideal, but often, particularly with the chronic UTIs, they sometimes feel not listened to, not believed. And one of the backgrounds to the webinar today is because we often hear that they take samples in, and although they are feeling very ill, it comes back saying that they don't have an infection and there's no prescription issued, or if it is, the next prescription doesn't work either. So they're very much in a catch-22 situation by that. So with ongoing symptoms all the time, you're really beginning to get very despondent as to what do they do next. And quite often that's the point that we hear from them. So we also provide them with some peer support, with some small group chats, because they feel very isolated. And some people want to speak to people who are in the same position, and they understand that even if it doesn't wave a magic wand, at least talking to other people in the same position can help them a lot. So we provide that as well. And that's just a couple of quotes, directly from people, saying how they feel. And I cannot underestimate the toll that it takes on both their mental health and their physical health, both from suffering from longer term infections and having lots and lots of courses of treatment, as well as trying to manage their everyday lives with flare-ups as they're going along. And a lot of them do feel that if the initial testing and diagnosis was better in the beginning, they wouldn't end up going down the road of going from an acute infection to what becomes a chronic infection later on. So these are the kind of things that, as you really summarises, what the patient perspective is saying. They just don't feel it's understood until it's experienced, which is why they're very grateful to have a listening ear from us. And a lot of it is about communication and the information that they're given, which again is where our resources can help, because we can provide you with resources to help with those maybe difficult conversations and information that's required. And because it affects not only their life, but everybody around about them's life as well. And fear and dread do become the watchwords. We do hear that often. And again, it's not overly dramatic to say that some people feel that at times when they have flare-ups with their infections and they just don't know where to turn, they actually begin to feel suicidal about it all. And then there is the bigger picture of the greater sort of public health challenge with all of this, and the much wider aspect, the pressure that it puts, the extra pressure it puts on health services with these long-term infections, which I do think a chronic UTI is just beginning to be thought of as a long-term condition, because some of the people we speak to have suffered for long periods of time. We do see people coming to the end of the tunnel and having different types of treatment, who are people who are maybe being referred to the clinic at the Whittington in London and are having long-term antibiotics, and then using things like Hyprex, and Dr. Peter will speak much more about that. But the economic burden, the way that they can't work, the flare-ups that they're having, which cut short all their normal social lives, and everything that the rest of us take for granted, has a huge impact on their mental health. So if we were to ask, what would you like to change in an ideal world? And we all know that it is not an ideal world in any stretch of the imagination. We know that AMR is multifaceted and complex, but there are some things that we all can do, and there are some things that we can work towards. But this would be their wish list of better diagnostics. We know new antibiotics is a really tricky one, but they're beginning to be looking at other alternatives like phages and vaccines. People spend a lot of money in their desperation going for private treatment, trying to go abroad, trying to look using alternatives, often herbal alternatives, all sorts of different kinds of alternatives, which you really don't get them anywhere at the end of the day, feeling really quite desperate with it all. Because the only tertiary centre is in London and there's a long waiting list for that particular clinic, not having any accessible regional centres doesn't help with the inequality side of this, that people are having to spend a lot of money and travel to get a different type of treatment. Not realising just the extent of the suffering that is caused by it, and the number of people who are suffering, and looking for support to reduce their isolation, which again is something that we can help with. So I'm not going to talk about that anymore. I've given you a bit of a very whistle-stop through, but I'm now going to show you a short video, just last 5 minutes, from a lovely lady, Mary, who's been involved with our charity for some time, who does suffer from a chronic UTI, and I will let Mary's words speak for themselves.
My name is Mary. I live on the east coast of Scotland. I'm married with 2 grown-up boys. I've just recently become a granny, which we're absolutely thrilled about, and I'm really trying and wanting to be well, to be a good, fit, fun granny. So I've been suffering with a urinary tract infection for 30 years since the birth of my second son. And it has gone from occasional infections, maybe once or twice a year, to 3 or 4 times a year, to a chronic condition that I find myself with now, whereby I can't come off the antibiotics, not even for 36 hours. And if I do come off the antibiotics for any reason, I become very ill very quickly. And obviously the antibiotics have massive side effects, particularly when you take them constantly. Living with an antibiotic resistant infection affects my life in various ways, but probably the biggest thing is that I live in fear all the time. You just never know when this thing will strike, and it comes day, night, anytime, and for me it arrives in a very violent fashion. I'm very quickly very ill, and any plans you've got are cancelled. What scares me most is about antibiotic resistance is the antibiotics not working. I fear one day I might have to have my bladder removed. I fear that this bug might actually get me in the end. It's really, really hard sometimes to keep your spirits up. There are days when I am barely functioning. And when you have an infection, you feel like your life is shrinking away from you. And there are days when you feel that your life is just not worth living, or a life like that is not worth living. And it materially affects your quality of life, and it materially affects my husband's quality of life. Really, if I'm honest, this situation for me has become desperate. You know, I feel desperate sometimes because I have got so much to live for. I've been blessed in many ways with good health, and I've had a lot of luck in my life. I've met a wonderful man to whom I've been married for 33 years. I've got 2 fabulous children and now a little grandchild. And this is a blight in my life. And there are times when I feel completely desperate about it. And I feel lonely and lost and trying to find an answer on my own. And it's very, very hard. Very hard sometimes. This is vital research that is being done for all of our futures, and it relies on charitable donations. So please contribute. I certainly will be, because it's my future and it may well be yours.
Okay,
Finished?
yeah. And I'm not doing a deliberate fundraising plug. That was a note video that was used when Mary was being an ambassador for us. But as a small charity, we are always open to donations. So if anybody does feel the need, then feel free. But that was not the object of that exercise. That little bit, we can't actually cut it out at the end. I'm sure you'll agree that it's a really poignant story to hear. And unfortunately, that is quite typical. The length of time for Mary is exceptional, but that is quite typical of the kind of feelings that people have, and the way that living with an infection day to day actually affects them. So it kind of shows you what is behind the statistics, the personal everyday toll that takes on people. So sorry about the IT hitches there, but I'm glad you managed. Thank you, Bilal, for clicking on that link for me. That was really good. So I'll just whiz through the rest because we've lost a little bit of time with that. You can see on the screen now. Can you see the what can you do screen? I'm hoping that's still there.
Your screen isn't being shared at the moment, Aileen. You can reshare.
Okay. Yeah. It seems to have stopped sharing. Oh, how do I show presenter view screen? There we are. No. Oh, IT pitch here, big time. Sorry. I can't see the bit that tells me to go back to sharing it again. That's what I'm clicking on everything here, but it's not sharing. Okay. So basically, I know we're going to share the slides with you at the end. So it's just the last couple of slides that I've got. Unless Bilal can help me find my screen sharing screen.
Yes, there we go, Aileen. We are sharing again.
Can you see it?
Yes.
Okay. Well, I think you probably, if I click on that one. Okay, we've now got presenter view. This link, which I won't try and do just in case it doesn't work, but that link on the screen now takes you to a Medscape page, which gives you some really good ideas about speaking to people about AMR. We also have lots of posts. We have a poster and we have lots of leaflets about talking to patients in your practice about specific infections, including penicillin allergies, which we get a lot of queries about as well. If I go back,
Aileen, Bilal is showing the slides, so just say when you want the next one.
Okay, can you go back a little bit then, Bilal? I'm so glad you're there. I'm just looking at what can you do? So I'm thinking with World Antibiotic Awareness Week next week, if you want to download our resources and use them to make a display in your practice, if you're working with any community leaders, we've had quite a lot of success where people have been working with travelling community or the Roman community, and they've actually liaised with them so that they can then spread the word amongst their own communities. So there is quite a lot you can do to cascade information and help signpost and refer people to us so that we can then help them and support them and help you and support you with your practice as well. So where are you, Bilal? Because I've lost where you are now.
Okay, Aileen, so yes, would you like anything else showing, or should we hand over to Peter?
Just finish up with our contact details on the last slide, please, to let everybody see our contact details, so where they can sign up to our newsletter and they can find us on all the social media channels. The links are all there. So so sorry about the IT hitches. Please do contact us. Please keep in touch. We've got a lot of information coming in our new website with lots more medical information there as well for yourselves and for your patients and your practice. And thank you for listening, and I'll just hand over to Peter.
Hello,
okay, Peter.
Oh,
over to you.
Hi. Can you see my screen? Can you see my screen?
Not being showed.
Oh, no, not yet. Okay, sorry. I need to share. Yeah. Sorry. Let me. Yeah. Okay. Can you see my screen now?
Yes, we're showing now.
Okay. So my name is Peter Mthali. I'm a consultant microbiologist. In the introduction, I was introduced as head of department. I'm no longer head of department. There's somebody younger, newer. But I'm the trust lead for antimicrobial stewardship at USCW. With me is my colleague, Dr. Dushanti Atukorora. She's a consultant microbiologist in the department as well. So she might help with answering some questions at the end. Okay, so here we go. So this is basically to walk you through the journey of a specimen from a patient to getting your results. And there's a bit of also new things, not really new things, but maybe not so common thing that we're doing about UTI in terms of management. So we talk about the, as introduction, impact of UTI. Then we look at pre-analysis phase. Then we look at analytical phase, post-analytical phase, and then some aspects of management. So the impact of UTI is quite great. It's a 50 to 60% of women who estimated to have at least an episode of UTI in their lifetime. Recurrent UTIs, which is 3 or more episodes in 1 year, or 2 or more infections in 6 months, affects 5 to 10% of women. So women are a bigger part of the population. That 10% translates to quite a big number. So UTI, infection of the bladder, mostly, but it can extend to the kidney, in which case the patient becomes septic. But for most patients who are having problems, it is the cystitis. So the infection starts from bacteria going in the bladder, and the bacteria can form a biofilm, which can be either on the surface of the bladder or it can be inside the cells. And the thing with the biofilm is that antibiotics don't work well with biofilms because we rely on bacteria to be multiplying for antibiotics to work. So when bacteria is in biofilms, they're not multiplying most of the time. They're what we call stationary phase. So the antibiotics are not very effective with organisms which are stationary phase. And they functionally, they will display as if they are resistant. But if you took such bacteria and put on the plate, it is not resistant. But within the biofilm, they are resistant because in the biofilm, you have reduction of antibiotics going in. Sometimes the antibiotics are actually flushed out by the bacteria. So it's it becomes quite complex. And if not properly treated, this can set up recurrence of infection. So UTI is quite expensive, psychologically, economically, and socially. We've heard the story from Mary, which shows how psychologically and socially she's affected by that recurrent infection. And it's very expensive to the NHS as well. Currently, it has cost of 37 million on antibiotics in 2023-2024, and that is not expected to change. In any case, we expect probably that will go up. Treatment failure can lead to complications and hospital admissions. And you can see with age, the admissions are increasing. So initially it's just women, but as we go along, men now become affected. So you can see that the numbers towards the end of life are quite large. So what are the psychological causes? Reduced quality of life, discomfort, urinary frequency, distress. If you have those things, you're not confident to go in the public because you're always looking for a toilet. And some places, it's difficult to come across a toilet. So that can make you stay at home. You're always anxious, stressful, and depression because you can't function normally. So it's a huge psychological cost. Social impact. So your relationships may actually suffer because of that. You can be in isolation, embarrassed because you want to use the toilet all the time, interfering with daily activities. So the social impact as well is quite huge. So just a word about the difference between women and men. So women, sexually active women obviously the ones who get in UTI a lot. But young men are not expected to have UTI. So if a young man has got UTI, there's something wrong with them. So that could be a structural problem in the bladder or the kidney that needs to be looked at. But however, when men have UTI, it's more difficult to treat because it can involve the infection of the prostate. And the prostate is very difficult to treat because not many antibiotics go in the prostate. And here I've listed the in ranking order which antibiotics can be used. And you can see the only reliable ones are fluoroquinolones, like Cipro, levofloxacin, and trimethoprim. The other ones which enter the prostate very well, tetracycline and macrolides, these have no activity against gram-negative that cause UTI. So they're out, even though they're very good into entering the prostate. And then beta-lactam, which are cephalosporins or ceftriaxone, these have not good penetration. So you may need to have quite prolonged treatment period to actually achieve cure. So let's look at the diagnostics. So when we are looking at diagnosis, we are interested before the sample is collected. That's the pre-analytical phase. So what's important? We have some guidelines when urine should be collected. So UKHSA has this guideline, okay? Urinary signs or symptoms. First, exclude these things. These are some of the things which could present as UTI. If yes, then you treat that particular condition. If not, then you proceed in the UTI process. You can use dipstick, but dipstick over 65 years not accepted. Should be those under 65. So it shows you here, okay, positive nitrate or leukocytes and red blood cells. Clinically, you have to make a decision. Is it UTI likely? UTI is likely, yes. And then you can send urine culture if there's a risk of resistance or pregnant. And again, here again, negative nitrate, positive leukocyte, yes. UTI equally likely to other diagnosis. Review time of specimen, send urine for culture and confirm diagnosis. So here we're trying to optimize therapy, and here we're trying to optimize diagnosis. So optimization of urine collection, clean touch, mixed stream collection. The genital area has to be cleaned before collection, and patients have to be educated how to collect it. The best urine is in the morning because it's more concentrated. Thereafter, if people have drank, the urine may be diluted. Again, we need proper storage and transportation. And the sooner it gets to the lab, the better. The more it stays, if there's no preservatives in there, then the bacteria, which was not significant, may start multiplying. And then we have a false picture when we look at it. We need at least 20 to 30 mils of urine. Then we look at, now the urine is in the lab. Now we're trying to analyze that urine. So the considerations for us is we have to fulfill our turnaround time. So we have standards to say the urine, when it gets to the lab, the result has to be within, say, okay, a day or 2 days. So we have to stick to that. And at times when machines are broken down and staff severe shortage, there's a backlog, and we might decide that those samples are no longer viable. So we may not process them. It's rare, but it happens. And then integrity of the samples. Some samples may come to us leaking. Those samples then will be rejected because they're not, the integrity is not certain. We process in the region of 15,000 urines per month. which is just shy of less than 200,000 a year. So this is one of, I should say, the highest volume throughput in the lab. So we can't cope doing it manually. So we use a machine. It's called Sysmex. So the machine is able to look at the urine. It can detect there's bacteria in the urine. It can detect the red cells, white cells, as well as epithelial cells. So based on that, the machine can reject the sample to say there's no indication for UTI, therefore don't process. But if the sample passes that threshold, then it's going to be taken through the next stage, which is culturing and making sensitivities. So looking at the results, your results will come like this on the report. The antibiotics with a star, these will not be on the report. Only us can see these. We have to release them. A note on the epithelial cells. So we've got squamous epithelial cells. These are from urethra or vagina. High numbers may indicate contamination of the sample. So in that case, you have to be careful how you actually interpret the result. Transitional is in the blood and ureters. Again, high numbers may indicate maybe irritation or infection or something else. And then these renal tubular cells, if you find these, then there's something wrong with the kidney. So probably patient may be having an underlying renal problem, which obviously requires maybe a renal referral. So we constantly look at our antibiotic resistance to see whether we are matching what we are recommending and what is actually happening. So you can see here, these are our antibiotics for UTI. We've got fosfomycin, which is down here. Resistance is in the 10% or thereabouts. And you've got mesalinum. At the moment, resistance is the same as fosfomycin. Nitrofurantoin, very consistently quite low resistance. So the best antibiotic for UTI. And then we've got trimethoprim, which is resistance very high. At some point, it shot up there, but here we are always above almost 30%. So following that trend, you can see that this is our antibiotic guidelines. The standard treatment, we have nitrofurantoin, which is very reliable. The only problem is if glomerular filtration falls under certain level, is then not good. So we have pivmesalinum, which is also called mesalinum, a second line, and fosfomycin. So we don't actually have trimethoprim in the standard treatment because the resistance is high. And then we where there's allergy, that's where we introduce trimethoprim as third line, as well as here. So a short story about trimethoprim here is that around this time, we took it out of the guidelines. And we didn't use trimethoprim for some time. We just introduced it around here. So you can see the resistance, almost 60% maintained, and then it dropped. We've not been using trimethoprim. And now it's dropped enough, but still we can't make it like first line because resistance is too high. So occasionally we get challenging results. It was challenging to us as well as you. So here we have Pseudomonas, completely resistant to everything that, the only oral option is ciprofloxacin anyway. But the other and Pseudomonas antibiotics are all resistant. So which means this patient may be well, but with symptoms of UTI, well, you can treat them in the community because there's nothing here, okay? We have this new ceftazidime tazobactam mixture and ceftazidime avibactam mixture, which we have to ask for. Very expensive, so patients may have to come in for that. So you can see that resistance has got a huge bearing on patients and the system. So post-analytical phase. So sometimes we get these samples. We are not getting enough information. So we don't know, sometimes it's from a catheter, sometimes it's not from a catheter. Sometimes the patient hasn't got any symptoms, but we don't know all that because it's not given to us. So we say dipstick, okay? Don't use it on catheter urine because the catheter is always colonized and it's always going to be positive. And if this is from a dipstick, we don't treat it unless patient is systemically unwell. And even if there's no catheter, a patient has no symptoms, we call that asymptomatic bacteriuria. We don't need to treat it. So those are the some of the nuances about a positive culture. So catheter, urine, patient not systemically unwell, no treatment. Patient has no symptoms, but somehow urine was collected and it's brought something, no treatment. So you may also get results like this. So we have S is sensitive, I, we say increased exposure, okay? Some people may think of it as intermediate, but what it means is ciprofloxacin is not resistant, but it's not sensitive either. So you need to increase the dosing for it to be effective. And in general, so we got ciprofloxacin as a quinolone, piptazo is a beta-lactam. So beta-lactams, the most effective way they work is the period the bacteria is exposed to it. So to increase dosing, in that case, we increase the frequency. So standard dose is 3 times, but with I, we recommend 4 times. The same dose, but 4 times. So we're increasing the amount of dose, but by frequency. Ciprofloxacin is mostly considered to be most effective by how much concentration it achieves. And these ones, normally we increase the dose itself, not the frequency. So here, normal dosing is 500 BD, but we'll ask that it should be increased to 750 milligrams BD. What are the non-antibiotic treatment alternatives? So the one which is very convincing is hipurate, methamphetamine hipurate, okay? It comes in some other standard trade names. This has been compared experimentally in clinical trials between hipurate and patients being on nitrofurantoin or trimethoprim or cefalexin, 12 months as prophylaxis. It was found that there was no difference, so it was not inferior. So in other words, you could use hipurates to prevent UTI instead of antibiotics, because with the use of antibiotics, what we see patients on prophylaxis, they start with trimethoprim, it quickly becomes resistant. Then you tend to cefalexin, becomes resistant. Then you tend to nitrofurantoin, becomes resistant. And then you tend to, then probably run out of choices. So there's no prophylaxis then. So which means the patient cannot be on prophylaxis, but treatment is also more difficult. because you haven't got any oral options left. Here's another smaller study. Again, this demonstrated there was no difference between antibiotic prophylaxis and the use of Librex. So it's something, and this they only used trimethoprim. So it's something that should be considered. And I think some patients and some people are using this. There is a vaccine which is called Uromune, and this has been shown to decrease the number of UTIs in women. So some patients were given a placebo, which it means something which doesn't actually work. It's a disguised thing. And then given the vaccine. So 56% women were free of UTIs compared to 25%. So it was convincing. And this is actually, the company is Spanish. So obviously it is licensed in Spain, Mexico, Dominican Republic, but it's waiting approval in many of the European countries. And maybe in the future, we can contemplate the use of phage therapy. Phage therapy is not licensed in the UK, but I know in France they do use quite a lot. The only drawback with phage therapy is that the phage itself, which is a virus, which attacks the bacteria, is very specific which bacteria is going to attack. So for you to be precise, you actually need to collect the bacteria which is causing the infection, and then send it off so they can find the right phage for treatment. So it's been used quite successfully in complex orthopedic infections where there's no longer an option of operation because the metal still stays in. It needs to be staying. And then the biofilm and antibiotics will not work, but phages can go in there in the biofilm and actually kill the bacteria. So it might be a way forward in the future that those suffering with chronic UTI, maybe phage therapy might be an option worth looking at. I found there's a new antibiotic, gepotidacin, which shows non-inferiority to nitrofurantoin. But it is by no means an antibiotic that you can say, oh, we've solved things now. We've got the super antibiotic. No, it's not. It's just really just another addition, just like you may have fosfomycin. So it's not really something that, yes, it adds something, but it's not something that you could be so excited about. So in conclusion, UTI is one of the most important infections that has major psychological and social impact. And the impact is more pronounced in those patients who are having recurrence. Its economic impact on NHS is significant. And a patient like Mary may not actually go to work because going to work is actually torture because they can't actually access the toilet maybe as frequent as possible. So we need to optimize the diagnosis and management to improve the outcomes of these patients. So thank you very much. That's all I wanted to share with you. Thank you.
Thank you very much, Aileen and Peter, for that. That was most insightful. We've had some really good questions coming in whilst you've been speaking. I'll start off with we have found most of our AKIs have been linked to UTIs and urosepsis in the past 5 or 6 months. Is there anything to be done to prevent an AKI upon finding out the patient has a UTI or urosepsis?
So in these patients, if they don't have background kidney problem, I'm not sure, but what I suspect is some patients who have a frequency they may avoid to drink properly to avoid that increased frequency going to toilet. So when you're dehydrated, then yes, you get acute kidney injury. So that I don't know, Dushante, what do you think?
Yeah, in the community, that would be one thing actually, to encourage people to take the oral intake. In the hospital, sometimes we see patients coming with sepsis. So probably the fluid management is also important in managing the patients so that the patients can come out of the AKI, and then we can use the antibiotics also appropriately, because sometimes we have to adjust the dosing of the antibiotics according to the renal functions as well. So yeah.
Okay, thank you. And a really interesting one coming. So how should you go about obtaining a sample if a patient is incontinent?
Right, that is difficult. I don't know if the companies trying to figure out what gadgets could be used. Even in the hospital is quite a challenging thing. In the hospital, you got the luxury of probably catheterizing the patient to get the urine. But in community, there's no such luxury. So it's quite difficult. I don't know. Have you got any answers?
No, it's the same answer actually, because difficult, if it is incontinent, I mean, very difficult to collect a sample in the community properly. It will be contaminated if it is not collected properly. So the organisms that we may isolate from the sample may not be the actual pathogens causing the infection.
Okay, and why are elderly patients at higher risk, especially those with symptoms such as delirium? And does cranberry juice, or are there any other sort of dietary advice issues that can be given?
So I don't think I captured that question properly.
Why are elderly patients at higher risk, especially those with symptoms such as delirium? And does cranberry juice, are there any other dietary advice that can be given to help minimize the prevalence?
Okay, so I saw somewhere some data showing how much the elderly are dehydrated. And because with age, the sensor in the brain of dehydration doesn't work well. In fact, also I heard somewhere that even for people who are not elderly, it is not a very fine system sensing whether you are dehydrated or not. And it can easily be confused between being hungry and being dehydrated. So some people might eat thinking they're hungry, but they're actually dehydrated. So it's not and it's very pronounced in the elderly that they don't drink enough. And because they don't drink enough, maybe they've got residual urine in the bladder. They can't go to the toilet because there's not enough being going through. So I think there's that aspect. I don't know what other aspect you, Dushante.
Nothing much to add, Peter, for that.
Yeah, but definitely the elderly need to be actually, I was even thinking there should be a measure to say how much has my granny or my dad drank, okay, to make sure they are really hydrated properly.
Okay, thank you. And a final one, I think this, Aileen, is probably better aimed at you, but are there any leaflets developed by Antibiotic Research UK on UTIs? What information is available?
Yeah, we have a lot of leaflets. We have general leaflets on different kinds of infections, including UTIs, on the website, and then we have specific leaflets on specific bacteria. If somebody already knows what the cause is, we've got information on that, and we will also signpost them to other information as well, because there's, obviously it's the other websites too. But we have a lot, and We've also are in the middle of revamping our website, and we've had a huge medical writing project. So we have a lot of new information which isn't up there yet, but soon will be. And so anybody who's if you can't find what you're looking for, please do get in touch with us, and we'll be able to give you some of the stuff which is maybe not on the new website yet. But we've got a lot of much more information to come through, which will be interesting for both healthcare professionals for background and for the public if they're giving out information leaflets as well. So if we don't have it, we can usually find somebody that does have it, but we do have a lot of information on the website. And if you have trouble navigating the website, just that was nearly a Freudian slip there, wasn't it? Then please just come to us, because we can help direct you to specific pages if you're not seeing what you want.
Thank you, Elaine. And Peter, final one. Who's asked, what would you give a patient in the first instance if the patient is allergic to nitrofurantoin?
So we've got good options there, as I showed before. We have fosfomycin, which is very suited especially to women. In men, it's not licensed, so it's a single dose in women. In men, you may have to give a second or third dose. We also have mesalinum, also called PIV mesalinum, which is a penicillin. That is an option. If the worst comes to the worst, we can use a ciprofloxacin, but that is if we've got an isolate and we have shown that the other antibiotics are not working or they're resistant. But otherwise, trimethoprim is worth trying as well, because you got about 80% chance or 70-something% chance of getting it right with trimethoprim, with the kind of resistance we have around.
Okay, thank you very much. Well, that concludes the webinar, everybody. You will be receiving an email link to a download of the whole presentation on Friday, and anything further you may need to ask in terms of questions, available information, please get in touch with Antibiotic Research UK, who, as you've realised, are more than happy to help. So thank you very much, everybody.
Thank you.
Thank you.
Goodbye.
Bye.